Okay, welcome to the Intelligent Healthcare course. So this week we will talk about phenotyping Alzheimer's disease using EEG data. That was the original title that I put in the agenda. But I just want to simplify the title that's, to emphasize the need of phenotyping Alzheimer's disease. So basically, in today's workshop, I will show you how to phenotype Alzheimer's disease based on questionnaires, and also I will provide the calculated EEG power data for you to practice on clustering analysis. So I believe that after last week's course that you should have some insights into what it is the clustering analysis and what's the potential applications of clustering analysis to the medical data. So this week we will just focus specifically on Alzheimer's disease, I think, which is a very important neurodegenerative disease in not only in the neurology but also in the medicine. Okay. So I'll just take Taiwan as an example because Taiwan is a country that we have a very rapid rate of aging, and this is an estimation of the Taiwan's structures of population. You can see that in 2013, that the working age, which is defined as between the age 15 to 64, which is the main workforce of the society, in 2017, that percentage was about 74%. And at that time, there's 12% of the youth, which is in a range of the under 14 years old, and also for the elderly, which is defined as the ages over 65, and at that time it was the 14%. And by 2025, that percentage will increase to 20%, and even 42% in the 2060. So the main reason behind this potential change is because the birth rate in Taiwan is quite low. Yeah, actually, compared to the countries in other parts of the world, that Taiwan's birth rate is among the lowest in the world. So that would be the problem, because when these working age people, when they pass beyond the 65, then and also because of the modern medicine, everyone have a very long estimated the lifespan expectancy. So the rate, the percentage of the elderly will be increased significantly. So that is not only the phenomenon in Taiwan, but actually the problem also in the world. If you there is a saying that if you just live long enough, you probably will have decline in cognitive functions, and that is sometimes you will think that is about dementia. Dementia is quite a rough term to describe a significant decline in cognitive functions and also the brain functions in the older age. So this is the whole pictures about the world. So in America, in 2015, there was an estimate about 9.4 million people were having dementia, and by 2030 and 50, the number will be increased to the 15.8 million and also nearly 30 million people, respectively. And also, the picture is roughly the same throughout the world, and particularly in Asia, because the population is highly condensed, and also there's a low birth rate for example, in Japan, in Taiwan, and even in China. So the rate of the dementia or the prevalence of dementia will be increased to maybe 67.2 million by 2050. So that would be a huge issue, because dementia is really, like the term says, it's a neurodegenerative disease. So it will affect not only cognitive function, but every aspect of the everyday living will be influenced by this disease. And of course, the dementia will lead to the death of the people, usually because of the complications, because of the other conditions that are associated with dementia, like infections or the other problems. And it is estimated that global death from dementia per 100,000 people is quite significant in North America, in Europe, and also in part of the East Asia countries. So that was a very important issue. So there are lots of studies try to find out the treatment of the dementia and also the early diagnosis of dementia, and see if we can prevent people from progressing to the real dementia if someone has the mild cognitive impairment. But the first thing we need to know here is that normal aging is not equal to dementia. So almost in every aspect of our human body and physiological functions, including the brain functions, will be changed associated with aging. So normal aging is quite working definitions that just follow the aging trajectories, but not falls into any kind of pathological problems. But actually, the aging itself, it can profoundly affect the brain structure and functions. So if we are able to trace a huge amount of the normal, healthy people across different ages, probably we'll see this kind of curve that, for example, if we try to measure the cognitive functioning from age 50 to the older age, then you will see a gradual decline in the cognitive functions that is associated with normal aging, but that is should be differentiated from the pathological conditions such as the mild cognitive function and dementia. So obviously, you can see that the dementia and MCI is on the same trajectory, that MCI is just a transition from the normal aging to a more rapid decline of the cognitive functions. So that is a pathological trajectory compared to the normal aging trajectories. So what is the difference between normal aging and dementia? So let's just cite this table and just for your reference. And in general, the normal aging should be independent in all activities of daily living, which is the so-called ADL, the activities of daily living. And in contrast to normal aging, the patients with dementia is dependent on others for ADL. And in normal aging, people make claims of memory loss, but can recall incidents of the forgetfulness. And in contrast to this, the dementia people may report memory loss if asked, but unable to recall instances of the forgetfulness, meaning that the patient with dementia usually don't know about their memory loss, but the symptoms were usually observed by families. And in normal aging, patients more concerned about memory loss, and so in contrast to that, the dementia people is often reported by the family to have memory loss. And also the normal aging has a recent memory of events and conversation intact, and occasional difficulty in finding words. That is quite common in older people and even in middle-aged people. And also no history of getting lost in family territory, may pause briefly to reorient, able to operate common appliance, normal interpersonal and social skills. And all these actually can be categorized under the first criteria, which is independent in all activities of daily living. So that is the quite important difference between the normal aging and patients with dementia. So dementia is quite a loose term, covering several types of the neurodegenerative disease, which is including Alzheimer's disease, vascular dementia, mixed dementia, which is combination of the Alzheimer's disease and vascular dementia, and also there's a rare form is a dementia with Lewy body, or other rare causes of dementia, for example, the CJD disease or frontotemporal dementia. And you can see that the majority of the dementia cases are Alzheimer's disease. And the main features of Alzheimer's disease is a physical disease caused by changes in the structure of the brain and a shortage of important chemicals that help with the transmission of message. That is quite a lay explanation of the Alzheimer's disease. And this disease was discovered by Dr. Alzheimer, and he just have a very well defined study on this type of the decline in cognitive dysfunctions. So that's the disease named after the Dr. Alzheimer's. And we should know that there is a vascular dementia, meaning that there's the dementia was caused by the problem in the, like for example, the cerebral stroke or infections or even hemorrhage, and that would be significantly affect the brain functions because of the blood problems. And it comprises roughly 17% of the cases, and also the people may have Alzheimer's disease, but also has the incident of the vascular problems. Then you will combination of the two causes. And if you want to differentiate the Alzheimer's disease and vascular dementia, there's an easy way to differentiate these two. And usually we can ask or examination the course of the cognitive decline. If the course is gradual decline in the cognitive functions, there is no stepwise decline in the cognitive function. For example, people may stay in a certain ability of cognitive function for a few years, but suddenly decline to worsen, the symptom worsens in a short period of time, and then stabilize for another period of the years. Then that is probably you will see that pattern is in vascular dementia, because vascular dementia is the course of illness is dependent on the vascular events. So that events will will dramatically reduce the functions at that time point. However, in contrast to vascular dementia, the decline in Alzheimer's disease is usually gradual and is just not stepwise. Okay. So there are other causes of dementia. For example, dementia with Lewy body will cause a certain symptoms and is also related, similar to the Parkinson's disease, and you will have visual hallucinations and other psychiatric symptoms. And so these are the dementia we commonly see in the clinics. And about the progression of the dementia, and so the stage 1 will be the primary symptoms of the dementia, which is the cognitive impairment. And in this stage, there will be a forgetfulness and misplaced items. Then usually we'll observe a slowed speech in an affected individual, and there's a gait impairment, poor coordinations, and there may be psychiatric symptoms, for example, depression, and it's very difficult to differentiate from whether the symptom was caused by depression or the depression was a result of the dementia. So that would be the challenges of the diagnosis in the early stage of the dementia. And for example, the mood swings, agitation, that would be a manifestation of the early stage. And also from the impairment to the early stage, there will be continuation of this worsening of these symptoms. And usually in the middle age, there will be a severe impairment in the activity of daily function, which is ADL. For example, unable to dress, cannot do things without assistance, and cannot recognize names of people. Maybe in the worst case, maybe have loss of the spatial awareness. And sometimes the people may have incomprehensible speech. But in the late stage, the people may seem calm, but actually the people in this stage, the patient in this stage, will have a very poor response to outside stimuli, and almost the bedridden, is dependent totally on the assistant and caregivers. So that would be roughly the fourth stage of the dementia. So you can see that even in the early stage or even in a cognitive impairment, it will cause a lot of problem to patients and its family. So that's why there's a strong need of the finding treatment or this care model for the dementia. So this is just showing what's the impact of the dementia on the brain. So usually in a mild cognitive impairment, we will see some problems in the hippocampus and temporal cortex, but the affected brain region will be enlarged in the moderate and severe dementia. Then usually it takes more than 8 years to see this kind of the course. And also in the clinical perspective, then we will have a rating scale, for example, the clinical dementia rating scale, which is try to measure the stage of the dementia. And there is also another scale called the MMSE, which is abbreviation for mini mental status examination. This is a collection of questions to measure the orientations, concentrations, short-term memories, calculations, abstractions, or naming abilities, or the drawing abilities, etc. So it's a very useful tools that to quantify the cognitive ability. Usually the score is defined between 0 and 30, and in healthy persons we should have a score above like 26, 27, and probably in a young age the score should be like 29, 30. So in the healthy conditions, the score will be very close to the 30, the full score, and we call this a ceiling effect. However, when the score is down, they will be very sensitive to the change in or diagnosis of dementia. However, that score is also affected by the education levels. For example, the people with higher education may have some ability to compensate his or her cognitive decline. So that MMSE score was determined not only by cognitive decline, but also need to be judged by the education levels. Okay, so but usually when the MCI was confirmed, then the decline in this scores seems to be inevitable. But actually, not every patient of MCI will advance to the Alzheimer's disease. Some MCI patients will just stay for a long time without significant decline or progression to AD. But some MCI patients do progress to AD. So that is also a reason we want to phenotype Alzheimer's disease, or even you try to phenotype a mild cognitive impairment using some biomarkers. So people now trying to study, for example, the amyloid deposit or tau protein, and to see if there are any biomarkers can differentiate why some people will have MCI but just stay have a stable MCI for many years, but some people may just progress to AD. So that is the need for phenotyping Alzheimer's disease, and that is the reason why I put this disease in the clustering analysis course. And so let's just try to give a very detailed explanation of the early symptoms of dementia. So, as I said, the dementia is not just about the cognitive changes. It will also affect the whole brain functions. So easily you will see there is high rate of the psychiatric symptoms in the patients of dementia. For example, the withdrawal, apathy, depression, anxiety, insomnia, which is inability to sleep, and fearfulness and suspiciousness, paranoia, which is becomes some just be very sensitive to some environmental stimuli, and to think not the thinking process is not in the reality. And also, if that is very severe, they will have abnormal beliefs, which is delusions, or even hallucination, means that you may hear or see something not exist in the real world. That is quite a complex phenotype of psychiatric symptoms in the dementia. And in terms of the cognitive changes, including the forgetfulness, trouble understanding language and comprehension, and difficulty finding words, not knowing common facts such as the name of the leaders in the country, and disorientations. And there's also other significant change, including personality changes, problem behaviors, or changes in day-to-day functioning. So that is, you can see that because dementia is a neurodegenerative disease, you can easily imagine that it will affect the whole brain. So that's why the symptoms of the dementia can have a lot of different kind of the manifestations. So if we want to look into the brain to find out the clues of dementia, sometimes it's not very easy, because just as I show you two images here, which is the T1 structures, brain structures of the scanning from two older people, and so you can try to make a judgment which one has the diagnosis of dementia. So in the older age, there is a brain atrophy associated with aging process. So that is a normal aging. But can we judge that this atrophy is because of the disease or normal aging? Is not very easy. Okay, so in this case, you can see that the right one is the dementia people and demented people, and you can see there is a more atrophy in the temporal cortex, and that is quite common in the patient with dementia. However, this is not diagnostically specific. So that's why there is no guideline or the golden standard for radiologists to diagnosing dementia just based on the MRI images. So that is our challenge, because if you can find an AI algorithm to quantify these subtle changes in the brain valence, for example, the gray matter valence, white matter valence, then we can probably more be able to detect the dementia not by our eye, but can just using the machine learning tools to help us to find early dementia. And it has been quite evidence that there's a brain atrophy in advanced Alzheimer's disease compared to normal aging. So this is the Postmodern Studies, which is the brain from the patient with Alzheimer's disease, and also the real brain from the normal aging people. You can see there's a lot, very significant brain atrophies in the patient with Alzheimer's disease. So that is corresponding to the figure I showed you previously, that the trajectories of the AD is more rapid and more steep than the normal aging. And also there's a very elegant studies published in 2005 showing that there's already a significant gray matter loss even after only 1 year after the diagnosis. So these columns show you the cortical thickness at the time point of the AD diagnosis, and this middle column show you the cortical thickness 1 year later. And if we take the difference between these two, because if you see, just look at the cortical thickness, you think that, oh, there's not much difference just based on colors, and our eyes can only identify big changes in, maybe your eyes is more sensitive than me, but I cannot see any difference if you just show me the cortical thickness by colors. But if you subtract these two maps and put in an appropriate scale, you can see that there's really a decline in the cortical thickness even only 1 year after of the diagnosis. So that's why the brain valence changes in the neuropsychiatric disorders is usually very subtle. It's not that visually identifiable. So that's why we really need mathematical analysis or even machine learning tools to help us identify this pathology. So as I said, there's quite a need for identifying functional and also structural markers, and there are quite a difference between these two kind of markers. So for example, I just cite this article that this is horizontal axis is the hypothetical time course of the AD disease, and the vertical show the percentage of the impairment. So for example, if the AD is diagnosis at the age of 70, then usually we'll observe a significant brain atrophy after the diagnosis of AD, including the temporal cortex, hippocampus, and also the entire cortex in the frontal areas. And also, so that's why we need to find some functional markers before the diagnosis of AD, because that functional markers, the change may occur prior to the changes of the brain structures. So for example, in AD, we now have a very promising markers, which is called amyloid markers. And that has a high presence of the amyloid markers in the AD patients. However, there's other need. For example, if we can measure EEG or electroencephalogram, which is the measurement of electrical activities of the brain, or even we can use in MRI, then probably we can using just MRI or EEG to diagnose dementia. So that is the whole pictures of the functional and structural markers. And as I said, because the dementia affect the whole brain, so there are lots of the symptom clusters, and so we call these clusters neuropsychiatric clusters of the symptoms in dementia, which includes apathy, aggressions, depression, even mania in a rare case, or psychosis or agitations. And these symptoms, sometimes we just call the behavioral and psychiatric symptoms of dementia, and can be abbreviated as the BPSD. So if you heard about the BPSD of the dementia, that means it refers to the behavioral and psychiatric symptoms of dementia. And in these slides, I will just show a very useful point by the Dr. Huang at the Taipei Veterans General Hospital. He's retired now, but he's a renowned expert of the dementia. So he just wrote a very simple wordings to help you to remember what is the BPSD. So first thing is that the patients do not have short-term memories and just keep on saying the old things, and cannot sleep, but the sleep pattern is very irregular, can sleep well, just sit on the sofa, but when you just go to the bed, patient cannot go to sleep, and can just wandering everywhere and can be lost after going out. And if something is missing, he just feels suspicious that he feels things is being stolen, and can have a repetitive speech and repetitive behaviors and unstable emotions. And usually the primary manifest of the dementia in mood is depressions. And then also is even the personality can change, because whereas if you just question that the thing's not stolen, then you just become easily agitated, then we have some aggressions. So that is the main features of the dementias in terms of the behavioral and psychiatric symptoms. And the prevalence of BPSD is actually very high. In study that 95% of patients affected by dementia will experience BPSD that are severe enough to be labeled as a problem during the course of their illness. So you can see that the challenges of the dementia is not only about the cognitive decline. Usually the presence of BPSD is the main problems that can cause the severe pressure and stress on the caregivers. And this PTSD can be quantified by a questionnaire called Neuropsychiatric Inventory questionnaire, which is called the NPI questionnaires, and including the 12 items covering the delusions, hallucinations, agitation, depression, apathy, mood elation, euphoria, anxiety, disinhibition, irritability, aberrant motor behavior, and any other symptoms. So you can see that there's quite high prevalence at the baseline and also 5 years later. As you can see, the rate is very high. So that is the one of the major challenges in caring patients with dementia. And the impact is huge because 50 to 90% of caregivers consider physical aggression as the most serious problems they encountered and a factor leading to institutionalizations. And also the frontline staff working in the long-term care center report that physical assault contributes to significant work-related stress. So really the mood and behavioral problems such as agitation, depression, anxiety, and even paranoid ideations causes these significant sufferings. And the etiology of PTSD is still under research. But in clinical, we know that the demented people usually have disruptions of circadian rhythms, and that can result in leading to the agitation during the day and restlessness at night, which is called sundowning syndromes. So it means that the patient have some not only have the problem in the daytime, but the symptom can even worse during the night times. So that causes the huge stress on the caregivers, because if the caregivers cannot sleep well, then no one can functioning well to give the best treatment for the patients. And also, based on the functional neuroimaging studies, the results suggest that PTSD are not random consequence of diffuse brain units, but are fundamental expression of regional cerebral pathology. So that is quite encouraging, because that is the basis of phenotyping Alzheimer's disease. So if we can find out what brain regions is associated with a certain behavioral or psychiatric symptoms, that would be a huge advantage, so we can find some treatment. However, we should know that some symptoms of PTSD is not treatable. So for example, the wanderings, urinations, inappropriate dressings, repetitive activities, hoarding behaviors, which is just put everything in the house, or there's eating inedibles, removal restraint, which is very commonly seen in the long-term care centers or in psychiatric wards, or pushing wheelchairs. Becomes inappropriate behaviors. These symptoms are usually untreatable, and there are lots of there are some evidence showing that even if you treat these people with the antipsychotics, the result is usually not beneficial. So this still quite the challenges of caring a patient with PTSD. And there are some symptoms that we can treat. For example, anxiety and depressive symptoms, usually the primary symptom we should treat, and also keep just high alert on this kind of symptoms. And also the sleep disturbance is treatable, and even the manic-like symptoms is treatable, and also likewise delusions and hallucinations. And So these are the psychiatric symptoms that we can treat with certain medications in patients with dementia. And I want you know that there's a kind of a good resources on the internet showing the current attitudes towards dementias, about the knowledges and behaviors. For example, in the layperson or general populations, 95% of the public think they will develop dementia in their lifetime, and 78 are concerned about developing dementia at some point. And most importantly, in there you can see that the medical resource for dementia is not enough. For example, here you can see that just under 40% of the general public think that there are adequate community services for people living with dementia and for carers. And the rate is not also high in, for example, the general, under 70% of the general public think there are adequate competent physicians for the diagnosis and treatment of dementia. So we really need more resources and research identifying dementia and even phenotyping dementias. So you can see that the consensus of these about dementia is that we really need targeted public health awareness campaigns to promote the knowledge about dementia and to provide a better diagnostic tools. So we can, this is just for your reference, so you can see what's the current attitudes of the general public to the dementia. And in terms of the machine learning or artificial intelligence, that there has been quite a progress in this area. For example, in the 2017, and there is a FDA approvals of AI-based assessments program called the CanTap Mobile, which can assess memories for the elderly just based on the app. So this assessment will generate a series of questions, and it can judge the probability of dementia based on the collection of the cognitive assessments. And so this is the public information for this CanTap Mobile, and it seems that it's just approval for the diagnosis of or evaluation of the dementia. Okay, so in clinics there are some efforts to trying to phenotype the subtypes of the Alzheimer's disease, and in this figure just published in Neurology this year's, showing that in the clinical aspect that we usually can define the AD by the severity and the symptom dimensions. For example, the right axis is just probably more typical, and the left is not typical. For example, usually the hippocampus or limbic system will be affected severely or commonly in the patients with AD, but in a typical cases there are some hippocampal sparing, and there's also including the younger age male sex, the ApoE4 non-carriers, the high cognitive reserve, or other kind of symptoms. And the other axis is the severity dimensions, which is typically the AD will have a severe decline in the cognitive functions, and also accompanied with the brain atrophy. But in the other side of this axis is usually we can see some patients with the minimal atrophies and a less extent of the decline in cognitive functions. So I would say that these classifications is not final, and so probably we should include more biological informations to define these subtypes more clearly. So that is just for your information, that's why there is a need for clustering analysis of the Alzheimer's disease. Okay, so I hope you enjoy these lecture parts and to understand the importance of the Alzheimer's disease and the need for the phenotyping the dementia. And so in the workshop, I will show you how to do this just based on the real data. Okay, see you in the next course. Bye-bye.